TCA is like the new one, although monospot is like really easy to remember that one. But and I think I also rearranged some slides because last time I was talking about this, I think I had some of these pictures were covering things up, so I just kind of moved them around a little bit. Again, with mono, you probably already know this, but you know it's a virus. It's the Epstein-Barr virus. There's not a lot you can do about it, other than just kind of wait for it to pass for however long it takes, right? 3 months, 6 months, who knows? Okay. As in, you're not going to use antibiotics because it's not a bacteria, right? Cool. All right. Moving on to GERD. So we have not talked about GERD yet. Yeah? Okay. You like the drawing of me? It was pretty good, I thought. No, not me. Anyway. So GERD. Yeah, anybody have a good GERD story? I don't know. You never know. No? Okay. How is this going to present, right? That's always the key question. How is this going to present to somebody? Is somebody actually going to come into the clinic, hospital, whatever, for GERD? Yay or nay? I mean, they'll come in for anything, right? But so if somebody comes in with this, what are you looking for? What kind of history do you want? What are the things that you want to be asking, looking for, so you recognize what it is, what's causing the problems, and then, of course, how to deal with it, how to treat it, or so on. This is actually a question for you guys. What do you think?
Heartburn.
Huh?
Heartburn.
Okay, so they're going to come in, they're probably going to be complaining of heartburn, right? Maybe something in their throat. Does it even say on here signs and symptoms about, yeah, a little sore throat, a little bit of cough, right? Okay, so again, not unusual at all because again, you got acid coming back up in there, so they kind of feel it, right? And this is also something that every once in a while somebody will think that they're having GERD and they're having a heart attack, and every once in a while somebody will be having a heart attack and think that they're having GERD, right? So just because of the area, right? What it's causing the problem with. Anyway, so this person comes in, they got heartburn, they're thinking, nah, it's not a big deal, and it probably isn't a big deal, right? So the questions you want to ask to kind of find out if it's a big deal is, like what?
How long have you had heartburn?
How long have you had the heartburn? What else? Always with time, you want to go time and frequency, right? How long have you had it? How much does it bother you? How often? Is it constant during the day? Is it, what? What else might you want to ask about it? Again, you're just trying to get a picture of it, right? Everything in this class is try to get a visual picture of what's going on.
Is it worse at different times of the day?
Is it worse at different times of the day? When do you think it might be worse with GERD? After you eat, nighttime? Is that what you said? Nighttime? Try to lay down, right? And the acid's more likely to kind of go up into the throat. Alrighty. So anyway, hey, how's that for a word? Esophageal tracheobronchial cough reflex. Right? and of course, you know, they throw in there acid in the distal esophagus stimulates a vaguely mediated. What's the vaguely mediated referring to? Huh? The vaguely mediated is referring to what? When they say vaguely. Vagus, right? The vagus nerve, which is our cranial nerve number 10, right? The wanderer, the one that goes to all, pretty much every organ in the body, right? Huh? Yeah. It is number 10. Yes, you were correct. So, vagus nerve. So when they say vaguely mediated, it's like, yeah, okay, whatever. We're talking about some organ-ish, right? Therefore, it must be the vagus nerve. It's going everywhere. Anyway, the vagus nerve is going to the esophagus, trachea, bronchi, and is basically saying there's something going on in here. You're getting acid back up in there. We're going to cause a cough reflex to get it out of there, make sure it's not getting in the lungs, right? Okay. What is Barrett's esophagus? You may have heard about this in previous classes. Johnson's like, yeah, okay, it's in the esophagus. Not the veins, no, it's actually the esophagus itself, but not the thing with the, what we were talking about before, where you had the varices in the esophagus, you know, that bled and coughed up blood, that kind of thing. No, we're talking about Barrett's esophagus is what we call it after you've had GERD for a long time, frequent, long period of time, and it changes the actual histology of the esophagus. Does anybody remember what that change was? Okay, turns it into columnar cells. Columnar cells are typically found in the stomach, right? Really long cells, you know, kind of keeps the acid up here instead of eating through the basement membrane of it, right? So you have these long columnar cells that work great for acid in the stomach, but because this person keeps regurgitating acid all the time in the esophagus, it changes, okay? What was it before, by the way? Does anybody remember the histology, huh? Stratified squamous or squamous. Those, you know, layers and layers, right? Because it's always stratified squamous anytime you have any kind of part in your body that can get friction, right? Got all those little egg-shaped cells kind of piling up on each other. Anyway, so Barrett's esophagus is the metaplastic change. If it is metaplastic from stratified squamous to columnar cells, can that be reversed or not?
Yes.
Yes, because the metaplasia, as we learned way back in week 1, is a reversible cell change from one mature cell type, stratified squamous, to another, columnar in this case, right? And then once the constant assault of the acid is done, then it can go back to its normal, okay? But in the meantime, you got a pretty red, inflamed, irritated throat, meaning the esophagus. And of course, we can stick a scope down there and look at it, or you can do a barium X-ray. Both of these shown here on this next slide. This is the barium. You can see it kind of lights up over here, and you can kind of see the reflux into that esophagus from the GERD. Okay, these are some of the basic treatments. A lot of it, you know, is this kind of home treatments. They should make sense to you, like anything though. When you look at something, you look at the symptoms, they should make sense if you understand what's going on, the physiology. Treatment's the same thing, right? Obviously, if one of the worst times it's going to be is at night when you're laying down, well, the patient may have to sleep sitting up in a you know, lazy boy or something like that. Okay? Eating smaller meals. Why would that make sense? Why would it make sense to suggest they eat smaller meals?
Not as much acid is being released to break down the food?
Possibly not as much acid yet.
Oh,
That's what you were going to say? Also, think about it. Say your stomach is this big. I don't know. Say your stomach is that big, right? And you put food in it, it's going to kind of stretch a little, right? Put a lot of food in, it's going to stretch a lot. The more that thing stretches, the more stuff is in it, the more pressure you're going to have pushing back at that lower esophageal sphincter, right? And if the lower esophageal sphincter is already kind of iffy or kind of weak, maybe even saponified or softened up, you know, from the fat, then, you know, it's more likely to push it back up in there, right? So probably a few different reasons with the acid and the just quantity of food can actually create a pressure to kind of shove it back up there. Back to the whole less fatty foods, again, fats can actually soften or saponify, turn into soap-like consistency of that lower esophageal sphincter. Okay, so eating a lot of fats can cause the problem, therefore eating less fats might help the problem. Okay, chewing gum should make sense. If you're chewing gum, you're constantly producing a lot of saliva, kind of washing it down throughout the day if you're chewing gum a lot, right? Just kind of keeping everything going that way. And of course, we will talk about H2 blockers and PPIs. When you say antacids, you have Tums, whatever, that kind of stuff, right? The basically bicarb, right? And obviously, if acid keeps coming up, you can neutralize it with the bicarb. Okay, but we'll talk about the H2 blockers and PPIs in a second. Anybody have any questions, comments so far about anything? Okay. This would be the Barrett's esophagus right here. Again, you can kind of see it when you take that endoscope and kind of look down the throat. You can see the redness, the irritation, how it's kind of angry. Okay. This clearly does not look good, right? Stick a scope down the throat and you see something like that, you're like, yeah, I may not be a surgeon here, but anybody can tell that is a problem, right? This looks really bad, and that even worse. Yeah. Anyway, by the way, the Barrett's esophagus can turn into cancer. How often? Did you catch that? Did it say on the slide? Yeah, about 1% of the time it can turn into cancer. Obviously esophageal cancer, but more specifically, typically we're talking about adenocarcinoma, ADENO carcinoma of the esophagus. Okay. But again, doesn't happen a lot, but 1% is still 1 out of every 100 people with this. Okay, which is why it's important to treat it, to not have it keep coming back up and be like, well, I'll be okay, right? Maybe you won't be okay. You may be the 1 in 100. Okay. So, not the best slide in the world to show it. I think the next slide or one after that shows the chemical formula that we're talking about here. But basically, you have 2 different mechanisms to stop acid production, okay, that are pharmaceutical. Now, having said that, these H2 blockers and PPIs, you can buy a non-prescription strength just at any drugstore, Walmart, Walgreens, whatever, and it's over the counter, right? Anybody can get it. So you may have heard of these before. I don't know, maybe even used it. Probably not. You guys are all pretty young. However, as you get older, every once in a while you're gonna be like, oh, I got some acid reflux. I think I need a whichever, okay? So you got your H2 blockers that obviously they block histamine. So this is your histamine receptor, H2 receptor. It's going to block that, which is going to decrease acid, okay? It's going to do it pretty fast, okay? So the H2 blockers are going to decrease acid production pretty fast. You get pretty quick relief. They're not really meant to take every single day all the time though, okay? So when you have something like that, what you're gonna do is you're gonna look on, honestly, I can't remember Zantac, Pepcid, blah, blah, blah. There's about a billion different brand names. I just remember the H2 blockers. What I'm doing is I'm looking for, it's either gonna say on the front or flip it around to the side or back, and it's gonna say the active ingredient. Those are all gonna be ranitidine, okay? Ranitidine are the H2 blockers. The proton pump inhibitors, those are the ones that you would take if you just pretty much constantly have acid reflux, right? Maybe you're a candidate for getting Barrett's esophagus because it just happens all the time. These are the ones that you would take actually pretty much every day. Just kind of take one before you go to bed every night and just kind of get used to taking it, because if you're taking these proton pump inhibitors, they are really effective. They're blocking the proton pump, which it's not really showing a great proton pump over here, but either case, you know, if you are kicking out protons, and we said before, protons are hydrogen atoms, right, as an acid. You also have chlorine going with this sucker. So you're kicking out your hydrogen and your chloride, and then, I said chlorine, didn't I? It's not your pool. And of course, you're making stomach acid, the HCl. But the proton pump inhibitors are pretty good for that. It used to be safe to say they're all kind of derivatives of omeprazole, except that now there's just so many different kinds, and so we have that. But again, this isn't something you take, oh, I got heartburn right now. You know, fine, take one, but it's probably not going to kick in for a little while, but it's going to last a lot longer too, okay? And of course, we do have prescription strength omeprazole, which is pantoprazole is like the main one that people will write prescription for. That's actually really good. It's pretty good. You can get a lot of relief from people that have long-term GERD with those things. Okay? So this was the formula I was actually looking for. Does that look familiar at all? That formula? Yeah, that's your general acid-base formula, right? And since we are talking about obviously acids, then we're back to this whole acid-base thing, right? So, yeah, just kind of my disclaimer when we're talking about acid bases, whatever it was a month ago, and you know, I always say, you know, yeah, because I draw that in the kidney, right? When we're doing the acid-base thing, which it does happen in the kidney, but obviously it happens in the stomach to produce the acid, because the end of this is you're taking that hydrogen right here and kicking it out through that proton pump, and of course you got your chloride, and now you have hydrogen, or hydrochloric acid, which is stomach acid. So if you're blocking that proton pump right here, then you are blocking the acid from being produced, and those are the other ones. Questions, comments? Just all sorts of fun? Yeah, I can see that clearly. And this is why I have no idea. I literally could not tell you. If you were going to give me a test on brand names of H2 blockers and PPIs, I would fail every day of the week, and I would have failed the same test 20 years ago. I just don't care because there are so many of them. Vast majority of them are not pharmaceutical grade. You don't need a prescription for. But you know, you're looking for, oh, this has got to be the one that sounds like omeprazole, but it's not, which means it must be the what, H2 or proton pump inhibitor. Proton pump. So this is the one that you want from your Fry's grocery store, right? Pick that sucker up, and that'll probably help you with long term, right? The one you're going to take daily, as opposed to oh, these are all proton pump inhibitors. Okay, forget it then. Again, I don't remember. Okay.